Welcome back to the deep dive. Today we're looking at something that really causes panic when it happens. The symptoms look exactly like a stroke.
They really do.
We're diving into idiopathic peripheral facial paralysis. Thankfully, it has a much friendlier name, Bell's palsy.
Yeah, and it's a really important topic because, while that sudden facial paralysis is terrifying for the patient, the way we diagnose it, the likely outcome, the prognosis, and crucially, the evidence for treatments, it's all become much clearer now.
So our mission today is basically to walk you through the latest medical guidelines, cut through some of that fear and confusion around this specific nerve issue.
Exactly. Be your guide through the sources.
Okay, before we get lost in the details, anatomy and all that, what's the single biggest thing people need to know right off the bat?
Probably two main things. First, it's actually not that rare. You see figures like 20 to 30 cases per 100,000 people each year.
That sounds like quite a lot.
It is, population-wise. But here's the kind of weird part. Your average GP might only see a new case, maybe once every year or two.
Huh. So common overall, but rare for an individual doctor's practice.
Precisely. Which, can sometimes lead to a bit of uncertainty when it does walk through the door.
Okay, and the second point?
The second point is the good news, generally speaking. In about 2/3 of cases, we never find a specific cause that's the idiopathic bit.
Right.
And the prognosis is, well, it's pretty favorable. Something like 65 to 85% of people get fully better, even with no treatment at all.
Wow. Okay.
But our focus, of course, has to be on understanding the whole picture, especially for those who don't recover spontaneously and what actually helps.
Right. Let's get into defining it. Peripheral facial paralysis, PFP. We're talking about the facial nerve, the end facialis, having some kind of functional problem. But this nerve does a lot more than just, make you smile, doesn't it?
Oh, absolutely. It's a mixed nerve, which means it carries different types of signals. So yeah, you get the obvious motor stuff, the droopy mouth corner, can't close the eye properly on that side. But patients might also lose taste on the front of their tongue or have changes in tearing, maybe dry eye, or even less saliva. And sometimes this weird thing called hyperacusis.
Hyperacusis.
Yeah, sounds become painfully loud. It's because that nerve also controls a tiny muscle in the ear, the stapedius muscle, that normally dampens loud noises. When that's paralyzed, everything sounds amplified.
Okay, so a lot going on. Now, the crucial first step in diagnosis is figuring out if this is peripheral, like Bell's palsy, or central, like a stroke. How does a doctor tell the difference quickly when someone comes in with a drooping face?
This is probably the most critical clinical distinction right at the start, and it really comes down to the forehead. Yeah. If the paralysis is peripheral, meaning the problem is with the nerve itself, outside the brain, it affects the entire half of the face, top to bottom. So the person absolutely cannot wrinkle their forehead on that side, and they can't close their eye tightly.
Wait, hang on. So if they can still move their forehead, that's actually more worrying?
Exactly. It seems counterintuitive, right? But yes, if they can still raise their eyebrows and close their eye, okay, but the lower face is drooping, that points towards a central cause, like a stroke.
Why is that?
It's because the upper part of the face, the forehead and eye muscles, get nerve signals from both sides of the brain. There's like a built-in backup system.
Ah, redundancy.
Right. So if one side of the brain has an issue, like a stroke, the other side can still send signals to the upper face. But the lower face doesn't have that dual supply. So central lesion spares the forehead, peripheral lesion hits everything.
That is a brilliant clinical pearl. Okay, so we've established it's peripheral. The sources mention grading the severity using the House-Brackman scale, HBI to 6. How does that help in practice?
It's just a standardized way to describe how severe the paralysis is. HBI is normal function, HBI is complete total paralysis, no movement at all. But the really key clinical jump is probably around HBIV. At HBIV, it's moderate weakness. They might look a bit off, but they can usually still force their eye closed with effort.
Okay.
Once you get to HBIV, moderately severe, they cannot close their eye anymore.
Damn.
And that inability to protect the eye, that's a major functional threshold. It changes the immediate management plan because of the risk to the cornea.
Got it. Let's talk about the cause, or rather, the lack of one. 2/3 are idiopathic, pop up really fast, usually within a day or two. But there must be a leading theory, right? What do doctors suspect is happening in Bell's palsy?
Yeah, we can't just say we don't know and stop there. The leading hypothesis, the one with the most biological plausibility, involved the herpes simplex virus type 1, HSV1.
The cold sore virus.
That's the one. It's neurotropic, loves nerve tissue. About 90% of us carry it. usually dormant in our nerve ganglia. The idea is that the virus reactivates and causes inflammation and swelling edema right in the facial nerve. Now, that nerve has to travel through a really narrow, bony tunnel in the skull.
Right, the facial canal.
Exactly.
Yeah.
So if the nerve swells up inside that rigid tunnel, it gets compressed, basically trapped. And that compression blocks the nerve signals, leading to paralysis.
That makes a lot of sense. But you mentioned only 2/3 are idiopathic. So about 1/3 of the time, there is a specific cause found for peripheral facial paralysis. What else are doctors looking out for?
Yeah, they have to rule out other things that can mimic Bell's palsy. Other infections are high on the list, like herpes zoster oticus, that's shingles affecting the facial nerve, also called Ramsay-Hunt syndrome, often way more painful, sometimes with little blisters in the ear.
Okay.
Then there's Lyme disease, especially in certain areas, or even mononucleosis. And then you have structural things. Did the person have head trauma? Is there a tumor growing near the nerve, maybe in the parotid gland, or a growth inside the ear like a cholesteatoma?
So when someone presents, time is critical. What's the biggest red flag that tells a clinician, hold on, this might not be simple Bell's palsy. This could be something slow-growing and serious?
The absolute number one thing is the onset. Bell's palsy hits fast, like bam, over a day or two.
Right.
If the weakness came on gradually, developing over weeks or months, that is a major alarm bell. It strongly suggests something is slowly compressing the nerve, like a tumor. That needs urgent investigation, imaging, the works.
Okay, gradual onset is bad news. Any other warning signs?
Yeah, things like really severe pain, especially pain that seems out of proportion. Fever, any signs of meningitis like stiff neck or severe headache, or if other cranial nerves are involved too, like if they have the facial droop plus double vision or numbness on their face, that suggests a bigger problem than just the facial nerve.
Gotcha. Now, are some people just more likely to get Bell's palsy? Are there risk factors, even if the cause is idiopathic?
It seems so. The evidence varies a bit between studies, but some things pop up consistently. Hypertension is often mentioned. But the clearest independent risk factor seems to be diabetes mellitus.
Really? Diabetes?
Yeah, people with diabetes appear to have a significantly higher risk of developing PFP. And there's also sometimes a family link. Maybe 4 to 14% of cases have other family members who've had it too.
Interesting. Okay, let's shift to prognosis and recovery. You said earlier it's generally favorable. 65–85% recover fully, even without treatment. Recovery usually starts within 3 weeks.
For about 85% of patients, yes, they'll start seeing some improvement within 3 weeks. But getting back to full function can take longer, sometimes up to 6 months.
But not everyone gets fully better. What makes the prognosis worse for some patients?
The two big ones are severity at onset and age. If someone comes in with just partial weakness, incomplete paralysis, their chance of full recovery is really high, like 94%. Wow. But if they present with complete paralysis, HB grade V or VI, that full recovery rate drops quite a bit, down to maybe 61%. Age is a huge factor. The older you are, the poorer the prognosis. For patients over 60, or especially over 65, the chance of a complete recovery can fall dramatically, maybe only around 36% in some studies.
Oof.
Yeah. And we also know prognosis tends to be worse in pregnant women and, again, in patients with diabetes.
So about 30% are left with some kind of long-term issue. The sources mention weakness, contractures, and this thing called synkinesis. Can you explain what that is? It sounds really disruptive.
Oh, it is. Synkinesis means joined movement or simultaneous movement. It happens because when the facial nerve fibers regrow after being damaged, they can get their wiring mixed up.
That's wiring.
Essentially, yeah. Nerve fibers that were meant to go to, say, the muscles around the mouth might accidentally regrow and connect to the muscles around the eye.
So what happens then?
So then, when the person tries to do one thing, something else happens involuntarily. The classic example is when they try to smile, their eye on that side might twitch closed or narrow.
Yeah.
Or when they blink hard, the corner of their mouth might pull up. It's like their face isn't obeying their commands properly.
That sounds incredibly frustrating.
It's extremely bothersome for patients, and it affects their expression, their symmetry, can make them feel self-conscious. There's even a rare specific type called crocodile tears, where they might tear up when they eat.
Wow. Okay, so those are the long-term potential issues, but let's refocus on the immediate danger. The thing that needs attention right now, day one. You mentioned the eye. Why is the eye at such risk in severe Bell's palsy?
It's purely mechanical, but potentially devastating. If you're HB grade IV or higher, you can't close your eye completely. That's called lagophthalmos. Plus, your blink reflex is weak or gone. and the lower eyelid might droop down, pulling away from the eyeball that's paralytic ectropion.
Okay, so the eye is exposed.
Exactly. The cornea, the clear front part of the eye, needs constant lubrication from tears and blinking to stay healthy. Without that protection, it dries out super fast.
And the consequence of that drying?
It can lead to abrasions, corneal erosion,
Yeah.
then infection, ulceration, and in the worst case, corneal scarring or even perforation. Potentially permanent vision loss or blindness if it's not managed aggressively from the start. It's the biggest acute threat.
So what's the absolute must-do intervention, even before medication?
Eye care. Non-negotiable. You need immediate, really diligent supportive care to protect that cornea. That means artificial tears, and lots of them. Preferably a thicker lubricating gel during the day because it lasts longer.
Okay.
And then, crucially, at night, they must use a bland eye ointment, something thick without medication, and tape the eye shut or use an eye patch or moisture chamber. You have to keep that cornea covered and moist while they sleep. This isn't optional. It's sight-saving.
Right, protect the eye first. Okay, let's move to the medical treatments. This used to be debated, but the evidence seems pretty solid now. What's the clear winner according to the latest meta-analyses?
Yeah, the evidence is really quite strong now. It points very clearly to corticosteroids, specifically prednisolone.
Prednisolone.
Yes. The standard recommendation, based on multiple large studies, is starting treatment within about a week of the symptoms appearing. The typical dose is something like 25 milligrams twice a day, so 50 milligrams total daily, for 10 days.
And this actually works. How much difference do steroids make?
They do work. Taking the steroids increases the chance of making a full, complete recovery by about 10 percentage points compared to placebo or no treatment.
Okay, 10% improvement in full recovery. That's significant.
It is. But maybe even more compelling is the effect on long-term problems, specifically synkinesis. The data shows steroids significantly reduce the risk of developing those troublesome involuntary movements later on.
How significantly?
The sources often quote, the number needed to treat, the NNT. To prevent one case of long-term synkinesis, you only need to treat about 7 patients with Bell's palsy with steroids.
NNT of 7. For listeners not deep in medical stats, why is that number 7 considered so good?
An NNT of 7 is actually really impressive for preventive treatment. It means for every 7 people you give the treatment to, you prevent one bad outcome in this case, the really bothersome synkinesis. It shows the treatment is having a substantial, meaningful impact on preventing that specific long-term complication.
So the benefit is pretty clear. Does that mean everyone with Bell's palsy should get steroids, even mild cases?
That's the current thinking, yes. Some older guidelines maybe suggested reserving them for more severe cases like IPAV or worse. But given the difficulty sometimes in predicting who will progress, and the clear benefit in preventing synkinesis even in milder cases, the consensus now is generally to offer steroids to basically all patients diagnosed with idiopathic Bell's palsy, assuming no contraindications.
Okay, steroids are in. Now let's tackle the other logical suspect. If the leading theory is HSV-1 virus reactivating, shouldn't antiviral drugs like valsiclovir or acyclovir help?
Yes, the intuitive thought. If it's herpes, kill the herpes virus.
Exactly. Seems logical.
But this is where the clinical trial evidence delivers a really clear and perhaps surprising verdict. Multiple large, well-conducted meta-analyses have looked at this specific question, and they consistently show no statistically significant benefit from adding antiviral medications.
No benefit at all, even when added to steroids.
Correct. No benefit from antivirals alone, and no additional benefit when you combine them with the proven steroids. They just don't seem to improve the recovery rate or reduce complications like synkinesis and idiopathic Bell's palsy.
Wow, so the intuition is wrong here.
It appears so. The evidence is pretty definitive on this point. One analysis even suggested that using antivirals alone might possibly be linked to slightly worse outcomes, though that wasn't the main finding. But the bottom line is, the guidelines are clear. Antivirals are not recommended. Stick with the steroids.
Good to know. Steroids, yes. Antivirals, no. Are there other therapies mentioned for the acute phase?
Yes. For patients who have trouble with speaking clearly or swallowing because of the paralysis, speech therapy, or logopedics is recommended early on to help manage those functional issues.
Okay. Let's try to wrap this up with the key takeaways for you, our listener. First, Bell's palsy, the idiopathic kind, is the most common cause of this sudden facial paralysis. But it's crucial to remember it's a diagnosis of exclusion.
You have to rule out the other possibilities, especially those sinister, slow-growing ones, by looking at things like the speed of onset.
Second, the absolute top priority right at the start is protecting the eye. That lack of closure is a serious threat to vision.
Absolutely. Lubrication, ointment, patching, it's mandatory and immediate.
And third, when it comes to medication, the evidence is clear-cut. Corticosteroids, like prednisolone, started early, improve recovery, and significantly cut the risk of long-term synkinesis.
And just as clearly, adding antiviral drugs doesn't help. No proven benefit there.
Okay. What about longer-term management if things don't fully resolve?
Yeah, if someone hasn't recovered well after, say, 3 months, they typically need referral to specialists. For those 30% or so who are left with residual problems like weakness, tightness, or that tricky synkinesis, there are options.
Like what? How do you manage synkinesis if it develops?
There are specialized therapies. Mimicry therapy with specially trained physical therapists or speech therapists can help retrain facial movements. And for the involuntary movements or tightness from synkinesis, botulinum toxin injections.
Botox.
Yeah, Botox. Used very strategically, it can help weaken the overactive muscles causing the synkinesis or contractures. And then for really severe permanent paralysis, there are complex reconstructive surgical options, both static and dynamic, to try and restore some symmetry and function.
Right. We've spent this whole deep dive talking about the physical nerve damage, the recovery statistics, the drugs. But let's end with this. We know about 30% of people will have some lasting visible asymmetry. Weakness, twitches, contractures, right there on their face. What does that actually mean for someone's life, their emotional well-being, their social interactions, maybe years down the line? It's not just about nerve recovery, is it? The sources really emphasize this. The potential for significant emotional burden, the need for psychological support, these cephalized facial teams, something important to consider beyond the physical.
That's a really crucial point to end on. The psychosocial impact is huge and often underestimated. Recovery isn't just about the nerve fibers. Thank you for joining us for this deep dive into Bell's palsy.